Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. Today, my name is Terry Fletcher. We are at our 230th episode, I still can't believe it, of the CodeCast podcast. And today I'm going to go back to coding. I know I did that recently with cardiology, and last week I was talking about the minor procedures with an E&M service. This week I'm going to talk about gastroenterology. I haven't talked about it on a podcast since 2020, so that's a long time. But I had the pleasure of presenting a GI endoscopy webinar for AAPC last Tuesday. So I thought I would just share some of my notes from that. And again, if you need a full webinar, please go to my website at terryfletcher.net. We have them on demand for all kinds of different specialties. I update them every quarter, and they also come with a PowerPoint and materials. So feel free to take a look at that. So when I talk about gastro, what I want to do is really just talk about detail to making sure that you're billing the procedures accurately. And you don't have to be a GI coder to want this information, because if you code for any kind of clinic or any kind of hospital system or physician system, so if you're part of, let's say, Providence or St. Joseph's or, any kind of system that basically, or company that employs physicians, then you're going to need to be pretty versed in some multi-specialty information. So first thing I want to do is I just want to give you some background from a clinical perspective on what a colonoscopy is, or I should say what type of a colonoscopy is, because you'll need to consider that detail before you report a service or before you code for it. And so it's always good to remember when you are billing for these services, basically to know when it's a screening, when it's surgical, when it is therapeutic, and know what the payer rules are as well. This is really important because you're not only going to have payer rules for Medicare, but then you'll have everybody else. And some of them are similar, some of them are not. So we want to give you as much detail as I can so that you are reporting accurately. So first, colonoscopies fall into 4 basic encounter types. You've got the screening, and this is basically a patient who presents or reports or calls up for a screening colonoscopy. They don't have sign or symptoms, and the screening is based when there's no sign or symptoms. Now, that is based on something different. That is based on patient's age, possibly gender, medical history, and or a family history according to medical guidelines. So there's a lot of options when it comes to reporting. It is defined by the population on which the test is performed, not the results or the findings of the test. So a screening colonoscopy describes a colonoscopy that is routinely performed on an asymptomatic person, because we're trying to test for the presence of colorectal cancer or colorectal polyps. Okay. Also, make sure you know your rules for screenings, and I'm going to give you a couple of those, because it does matter when it comes to age, gender, medical history. A certain patient population, certain ethnicities have some different rules as well. Now, we have a diagnostic and a therapeutic colonoscopy, and sometimes those get confused. So a diagnostic, that means you're looking for a diagnosis. So the patient has physical symptoms, such as rectal bleeding or pain, and the test is necessary to either rule out or confirm the suspected condition. So the sign or symptoms are used to explain the reason for the test, and that should be on the order. Now, a therapeutic colonoscopy, that's performed when the abnormalities are treated for the purpose of biopsy, tumor ablation, or other therapy. So it's a planned service that you're going in to do something specific. Very similar to diagnostic, except diagnostic, you're looking to figure out what you're going to do based on the symptoms. Therapeutic means you already have a diagnosis and you're going to go in and do something that's staged. Now, surveillance colonoscopy, similar to screening. This is when a patient is asymptomatic but has a personal history, now here when I say this, of possible gastrointestinal disease, colon polyps, or cancer. Technically, this is a screening with a different diagnostic coding or frequency guidelines, but make sure that you read the commercial plan's policy on this, because Medicare and AHA, American Hospital Association, they consider this from a diagnosis perspective to be a screening. But for example, some Anthem Blue Cross Blue Shield plans, some United Healthcare plans, they think that once the patient has any kind of polyp removed, even if they're asymptomatic, let's say, and they had a clean scan, that it's still considered a diagnostic after the fact. And so really read up on your commercial plans for that. But for Medicare, surveillance colonoscopy is considered a screening. Now, when you code for colonoscopy, the other thing you have to know besides what a colonoscopy is you need to know the reason for the encounter. So make sure you know whether it was preventative, which is screening, diagnostic, therapeutic, again, or surveillance, so you can pick the right code. So a screening colonoscopy, and this is really important, Medicare coverage for preventative colonoscopies. These are for patients that are age 50 or older. Now, I realize Medicare age patients are typically 65, but some Medicare patients are also disability Medicare, so they may have Medicare coverage, or it could be a secondary coverage from a spouse. But now, as of 2022, more of the commercial insurances, this used to just be 1 in 10, but more of the commercial insurance covers screening colonoscopies for aged 45 or older. But make sure you look into that, because I just ran across 2 policies for a payer and for a client of mine, that yes, it was for patients aged 45 and older, but it was only for African American males. And so ethnicity also plays a part in it based on statistical information for a certain patient population. So make sure you're understanding that. And a few payers even will cover earlier for individuals at high risk for colon cancer. But your commercial plans, they are contract related. There's really no consistency there. So make sure that you have all like a spreadsheet on what you need for that. For commercial and Medicaid patients, for the colonoscopy only, where you didn't do anything except a screening, that's a 45378. You need to append the modifier 33 for the preventative service, and I'm air quoting, and this triggers benefits. It means no cost sharing to the patient. And so this is described as colonoscopy, flexible diagnostic, including collection of specimens by brushing or washing when performed. And you'll also see in parentheses separate procedure. It means it's the base code, so you can't bill anything with it, otherwise it'll get kicked out. It's basically the bones code, it's the skeletal code. Now, when I say it triggers benefits, if this is the first line item and it has a 33 modifier and you have the right diagnosis, then that shows it was a screening, then the patient won't have a deductible or copay for the most part. Now, if there is the test actually turns into another procedure, meaning that let's say they went in there for a screening, but now the patient has a polyp or a lesion that needs to be removed, you also need to add the modifier PT for Medicare or 33 again for non-Medicare, because that means that the test converted to a diagnostic procedure. And we just want to make sure that we continue to get the benefits triggered for the patient, which waives their deductible. But it doesn't waive their 20%, not yet. Medicare has a sliding scale, but going into 2030, so every couple of years it changes. But for right now, the patients will still have their 20%. And then also make sure for Medicare, if you're doing a strict screening just for a high risk patient or patient who meets high risk, that would be a GO105. And so if they're not a high risk patient, so they don't have personal family history, or they're not a high risk patient for this, then that would be a GO121. And Medicare definitely has a policy on this. And so you want to look at Medicare Claims Processing Manual. It's Publication 104, Chapter 18, Section 60, and it talks about what is a high-risk patient. And they go into personal history of adenomatosis polyps, colorectal cancer, inflammatory bowel disease, possibly Crohn's, could be ulcerative colitis, family history of familial adenomatosis polyposis. That could be a close relative. Now they're talking about first-degree relative, sibling, parent, or child that has had colorectal cancer. And so just make sure that you're aware about the Medicare guidelines, because if not followed, you will get denials. They also have frequency guidelines, and make sure you're checking policies, because for high risk, you get one of these services. So it would either be a colonoscopy or a sigmoidoscopy, but all these screenings are once every 24 months and they're not allowed in place of each other. So if you had a colonoscopy, but then you, let's say 18 months later, had a flex sig, it won't be covered. Now, when you look at the diagnostic and therapeutic colonoscopy, now whether it be Medicare or whether it be commercial plan, you're going to go back to that 45378 code. That means when for example, the diagnostic colonoscopy, it reaches the cecum, so it comes all the way around. It starts at the anal opening, then comes around the sigmoid colon, the descending colon, makes a turn at the splenic flexure, comes down the transverse colon, makes another left turn at the hepatic flexure, comes down the ascending colon, and finally hits the cecum. So when you're dealing with that, I realized that the 45378 was the same code we build for commercial screening, but when it's diagnostic, we don't put a modifier on it. Now, let's say that you didn't get all the way to the cecum, so it was a discontinued procedure. And the reason for that, a lot of times, poor prep. Patient doesn't do what they need to do with their fleets or whatever was given to them for their prep. Then that's a 53 modifier, discontinued procedure. Make sure you know that's helpful, that you would code that instead of, let's say, a lowered value like a flex sig, only because you would be dealing with any kind of frequency guidelines and you don't want to kick that into play there. Also, when you're dealing with the how you list your diagnoses, one of the things that's really important is to try and make sure that your diagnosis for your screening exam, if that's how the patient came in and that's how the patient reported, that according to the coding clinic, and also the AGA, they had something in, the coding clinic had something in first quarter 2017. They said whenever a screening exam is performed, the screening code is listed first. Even if an additional procedure is performed as a result of the screening, in the event the screening turns into diagnostic, list the findings second, and then just use your pointer to make sure that the right diagnosis goes there. But remember, we're in the age of electronic billing. And in electronic billing, it picks up that first diagnosis. So when that first diagnosis is picked up, we are trying to trigger benefits, and when we talk about that, we're talking about out of pocket for the patient. So let's look at a couple of examples. So we have, let's say, a family history of colon cancer, procedure performed, screening colonoscopy. So if this was a Medicare patient, we would code GO105 because this is a high-risk patient. Okay, that's the HCPCS CPT code we'd bill. Now, would we bill Z80.0 for the family history? Yes, that should trigger benefits. 45378 with a 33 modifier, same diagnosis. This would go for a Medicaid or commercial patient. So make sure that you also put the 33 modifier on there because that could eliminate that cost sharing. Make sure you are checking copays, coinsurance, and deductibles with commercial plans because most of them, according to the U.S. Task Force and the AGA that we had, that they're supposed to waive all that in the same spirit of the rules as Medicare. But a lot of times I am seeing the deductible waive, but not the copay. Now remember, if you do also let's say the patient also needed an upper GI diagnostic, so an EGD at the same time as a screening, they're not going to waive the out of pocket. They're going to still keep it. It doesn't matter what you put on there because now the encounter is not for colorectal screening, it's for both. And so you have to make sure you are differentiating that. Let's see another example. So let's say we have iron deficient anemia, so a screening colon. And so we did a colonoscopy, and that is a covered diagnosis, even though the patient may be asymptomatic. But we have 45378. We want to take a look. Iron deficient anemia is D50.9. And then what would our test be as far as screening? D12.11. And so if this was a non-Medicare patient, we would have a 33 modifier on that diagnostic service. And then let's look at one that's an average patient. So let's say we had a colon screening for an average patient, but we ended up with polyps. Okay, so we ended up with polyps in the cecum and the sigmoid colon. Colonoscopy with removal of cecal and sigmoid polyp by snare. So 45385 would be your code. If it's non-Medicare, you would have a 33 modifier, but you'd also want to make sure that you have that first diagnosis as the Z12.11 because the patient was coming in for a screening. And then you have your D modifiers for the specific area that your physician gave you for the cecum and the sigmoid colon polyp. And then for a Medicare patient, still 45385, but the PT modifier would now reflect that there was a polyp removed but it started as a screening service. Now, here's a controversial thing. There is a diagnosis Z63.5, and that just says polyp of colon, but that is in the digestive system, and I would not use that use that diagnosis only because that is not going to trigger benefits. So if you're trying to waive the deductible for the patient, I would either use, let's say the patient had personal history of polyps, maybe the Z86.010 or the screening code. So, and even though the indication on colon screening, it may be average risk, but you want to use a screening code because they're being told to come in. If it's age appropriate, then you can still use that code. Also, make sure you don't overlook anesthesia. A lot of people do overlook that, but they also code it wrong. So let's say that it was moderate sedation, so Benadryl or midazolam, which is Versed, generic or something like that, or fentanyl. That's a moderate sedation. And for Medicare, this is only for GI, they want the GO 500 for the first 15 minutes. If it is for commercial, they want to see the 99152. Some payers want that 33 modifier to show that it was preventative because it also gets the deductible waived. But just make sure you know the 99153 is not an option. So that there's no value to it from a work value. Also, let's say that you did a lower GI endoscopy and it was, let's say it was screening 00812, but it was for propofol. So let's say you used a monitored, not a moderate sedation, monitored, meaning you put the patient to sleep. You have to go back to the anesthesia codes for that. And so you also want to get some pre-certs for that to make sure that you have that covered. Okay, so let me look at something here. So I got an interesting question today. And it's funny because I haven't looked at questions like this in a really long time, but I try not to do too much facility because I'm not a facility coder and I never claim to be, but I have stepped into doing some facility coding only because it's been kind of interesting with people will say, okay, well, what about this? What about that? I'm just like, okay, well, I can comment on it because I've done some research, but here's one of my coding questions that I got today. And it was a kind of an interesting question regarding a G code. And the G code was G0463. And that's actually an assessment and management code for a hospital. So it's for a hospital outpatient department or in a hospital setting. And it's not for Part B services. And the question from the listener basically said, can we bill this if a pharmacist is the one doing the assessment for medication management? And the answer is no. You also cannot bill for a pharmacist for any Part B services. Remember, a pharmacist is only covered under Part B, and there's no E&M value, there's no assessment value. It's only what they're doing with regard to dispensing medication. They don't have a consultative part of their licensure. So can they be a collaborative clinician with the physician? Sure, but only the physician can take that information, just like they take from their nurse or frontline worker or an occupational therapist or clinical social worker, and then they include it in what they're doing, even a dietitian. And then that helps build their case, and then they submit an E&M. So make sure you're not using a pharmacist when you're trying to capture some E&M services, whether it be hospital or anything else. That's just not a good idea. Okay, so I wanted to give you just a little bit of a personal tidbit. We're in the final stretch. I'm actually going to my daughter's wedding this weekend, so I was happy to get my podcast recorded before that. It's finally coming to fruition, so we're excited. We're looking forward to a very fun time. But one thing I wanted to say, you know what, and I can't wait to do this, I wanted to remind everybody to take a break. I forget to do that myself because with all my free time, I've been wedding planning. Or, sometimes I'm like, you know what, I just need to go sit in my room and fold laundry with the door open and just no sound. But sometimes it's just my zen. But you need a break from the computer. Take a break to just go outside, put some sun on your face, unplug your electronics, watch the trees blowing in the wind. If you have a beach next to you, I moved an hour out from the beach now. My entire life, I've been within 3 miles of the beach. So this has been interesting for me with our remodel, but just try to, and now I go down specifically an hour to the beach, but play with your pet, go to the beach, just take a break. And if all you can do is sit outside on your patio or even we call them window breaks, just look outside, look at the trees, look at the grass, and just look at things moving. All of a sudden you'll see a squirrel come down a tree or you'll see something. I was sitting there folding laundry this morning and I saw a lizard run across, my deck. So just take that time, because when you kind of just focus on nature and with no sound and you get rid of the electronics, it's amazing how it can give you a reboot. Just pulls you in just a little bit from that burnout phase. So try and do that if you can, and hopefully that just gives you just a little bit of a break and can make you feel better leading into the next week. All right, that's it for me this week. Everyone, make it a great day, a great week, and I'll talk to you next week on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.